You wake at 3 in the morning with your hand dead, and you shake it out over the edge of the bed until feeling crawls back in. By autumn, your feet burn as though the sheets were packed with hot sand. Somewhere in your chart, someone has written the word neuropathy. Nobody has measured anything. That word is not a diagnosis, it is a category. A nerve root compressed in your lumbar spine, a median nerve strangled at the wrist, a brachial plexus stretched at the shoulder, and small fibers dying quietly in the skin of your feet all produce numbness and burning. Only one of them is helped by an epidural. Each of them has a different natural history, and none of that history can be read off the word in your chart. My name is Dr. Gurpreet Singh Padda, MD, MBA, MHP, and I measure nerves at the Padda Institute Center for Interventional Pain Management in St. Louis. What offends me is not that this is hard. It is that in a 15-minute visit, the incentive is to name the symptom and turn the room over. Naming is fast, measuring is slow. You pay the difference in years. Let me show you what a nerve conduction study actually measures. A peripheral nerve is not a wire. It is a cable of axons, and the large ones are wrapped in myelin, a fatty insulating sleeve laid down by Schwann cells, interrupted at intervals by bare gaps. The impulse does not crawl along the membrane. It jumps gap to gap. That is why a healthy, large fiber conducts fast. We place a stimulating electrode over the nerve, a recording electrode downstream, deliver a brief pulse, and measure two things directly: time, the latency from stimulus to response, and the conduction velocity across a measured distance; size, the amplitude of the response, sensory and motor. Those two numbers separate two entirely different diseases. When myelin is damaged, the impulse loses its ability to jump. Latency lengthens, velocity falls, the signal arrives late. That is compressive demyelination, and carpal tunnel syndrome is its textbook example. The median nerve slows precisely across the wrist, while that same nerve conducts normally in the forearm above it, and normally again in the palm beyond it. When the axon itself dies, timing can look nearly normal, because surviving fibers still conduct at speed. There are simply fewer left to answer, so the amplitude collapses. The late responses, the F wave and the H reflex, time and impulse sent up to the spinal cord and back, interrogating the long proximal segment nearest the root, which the distal study never reaches. Slow means insulation. Small means wiring. The conduction study tells me about the cable. The needle examination tells me what the cable is running. In electromyography, I place a fine recording needle into selected muscles and listen. Literally listen on a speaker, all at rest and during effort. Healthy muscle at rest is electrically silent. Denervated muscle is not. It fires spontaneously. Individual fibers discharging with no motor unit left to command them. That is the acoustic signature of denervation, and it takes weeks after an injury to appear, which is why a study done too early can be falsely reassuring. That makes electromyography a localizing study, not a screening test. Every muscle is supplied by a specific nerve, from a specific division of the plexus from a specific nerve root. By sampling muscles that share a root but not a nerve, muscles that share a nerve but not a root, and the paraspinal muscles fed by the root's posterior branch, I can place the lesion on the map. Root, plexus, peripheral nerve, sciatica, diabetic polyneuropathy, and carpal tunnel overlap almost completely in how they feel to you. They do not overlap at all in where they live. An injection aimed at the wrong level or the wrong nerve cannot be expected to work. The injection did not fail. It was never aimed at your problem. The reform this specialty needs is not more testing. It is less testing, aimed better. Electrodiagnostic testing earns its place through diagnostic accuracy, not symptom relief. Before a single electrode touches your skin, I write down the question the study must answer. If I cannot write one, I do not run the study. A joint report of the American Academy of Neurology, the American Association of Electrodiagnostic Medicine, and the American Academy of Physical Medicine and Rehabilitation, England and colleagues, Neurology 2005 DAR, found that symptoms alone are relatively poor predictors of polyneuropathy, that signs on examination predict better, and that the most accurate case definition combines multiple symptoms. multiple signs, and abnormal electrodiagnostic findings. The American Diabetes Association position statement by Pop Busui and colleagues in Diabetes Care in 2017 is blunter still. Electrophysiological testing or referral to a neurologist is rarely needed to screen for diabetic polyneuropathy. It is reserved for atypical features, motor involvement exceeding sensory, rapid onset, or an asymmetric presentation for an unclear diagnosis, or when a different cause is suspected. If you have diabetes and classic symmetric burning feet, a clinic that tests you by reflex is performing a ritual, not answering a question. Now the limitation that matters most. Nerve conduction studies interrogate large myelinated fibers only. The small fibers that carry burning, temperature, and pain are invisible to them. So if you have furnace hot feet at night, normal strength, normal reflexes, and a normal nerve conduction study, you have not been proven healthy. You have been proven to have intact large fibers. The validated test is a punch skin biopsy of the distal leg, counting the density of intraepidermal nerve fibers, the Joint European Federation of Neurological Societies and Peripheral Nerve Society guideline, Loria and colleagues, in the European Journal of Neurology in 2010. Be honest about what testing costs you: brief electrical pulses, a fine needle, soreness, and bruising. Less common risks include bleeding or hematoma, local infection, and when the needle study must sample chest wall or thoracic paraspinal muscles, a rare risk of pneumothorax. Tell us beforehand if you take anticoagulants, have a bleeding disorder, have lymphedema in the limb, or carry an implanted cardiac device. When the answer is metabolic, here it frequently is, no needle placed in your spine will change it. Glycemic control is genuinely disease modifying, and that same diabetes care statement grades it honestly. A large relative risk reduction for polyneuropathy in type 1 diabetes, a far smaller one in type 2. Carbohydrate-restricted nutrition, omega-3 derived pro-resolving mediators, and red and near-infrared light therapy are all adjunctive and unproven for the nerve injury itself. They are not established care, and none of them is a substitute for knowing which nerve is injured. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. An adult arrives after 2 years of burning feet and a right foot that catches on stair edges. The chart says diabetic neuropathy, 2 lumbar epidurals have been done, and neither helped. Examination finds symmetric loss of pinprick and vibration in both feet, which fits the label. It also finds weakness of ankle dorsiflexion and eversion on one side only. That does not fit, and asymmetry is exactly the atypical feature the guideline says to test. Reduced sensory amplitudes in both legs, axon loss, length dependent, consistent with the diagnosis on the chart. But superimposed on it, the peroneal motor response slows sharply across the fibular head and is normal below it. And needle examination finds denervation only in muscles supplied by that nerve, with the lumbar paraspinal silent. That is not an L5 nerve root. That is a focal entrapment at the knee. The epidurals were aimed at a level that was never the problem. What followed was unglamorous. We treated the entrapment instead of the spine, pressure off the fibular head, a temporary ankle-foot orthosis while the nerve recovered, and we went hard at glucose control because the metabolic neuropathy underneath was still there. None of it was fast. The needle study was uncomfortable. The foot drop improved over months, not weeks, because a regenerating axon moves at its own pace and does not negotiate. The burning never fully left. It grew quieter across a year as glucose control tightened. That is a real result, not a cure, and I will not call it one. So if you have been told you have neuropathy and no one has measured a nerve, ask why not. The full explanation is on our Electrodiagnostics page at painmd.tv, Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Bring the question no one has answered. We will measure it. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.